that I did last week with Dr. Malone. I'll just run through it. We talked a little bit about it preoperatively last week, and she had her procedure last Wednesday. So just as a refresher, this was a 74-year-old woman presented with numbness involving both legs, progressive over the course of the last 12 months. She didn't have any discrete weakness or other signs or symptoms really of myelopathy. She did have some hyperreflexia in the lower extremities and was subtly weak in the lower extremities as well. This was a CT scan and MRI studies. We reviewed these last week showing intradural extramedullary lesion at T23 at the T23 level, and showing a cut through the lesion itself, and then spinal cord displacement ventrally due to the lesion. And then our planned surgery was a T23 laminectomy and excision. So first thing I would say about the case, I mean, we took a lot of time to try to dial in our skin incision and to localize the levels. This can be difficult in the lower cervical and upper thoracic spine, but we counted down from the top and then localized the T23 spinous processes and where we were going to do our surgery. Laminectomies were performed, and then this is showing sort of our attempt at sort of maintaining meticulous hemostasis around the dura and spinal cord intraoperatively. And then we made our midline durotomy. I don't have a ton of photos, but I do have a video after the lesion was just about to be taken out. So
this is Rob, by the way. This is a buddy. You missed your call in, Rob. You've been a great neurosurgeon.
Thank you for saying that. I certainly was fairly nervous during this part of the operation. I don't lie, but it was certainly very fun, and it was a really exciting case, and did learn a lot, and got to utilize some microsurgical skills. So that was quite fun. So this is basically right at the and then showing that we had good resection, good gross resection of the tumor, and then we performed our durotomy and we closed our wound. I'll just forward this. I don't know. Next slide. Sorry. So okay. Last week we talked a little bit about these versus intramedullary lesions. And I'll just kind of slide through these, but I wanted to talk a little bit about, just quickly about a technology that we used intraoperatively to localize and to sort of look at the morphology of the tumor. This is certainly an older technology. Ultrasound has been around for a very long time, but in terms of its use in spine surgery, I think for orthopedic surgeons, I've not really known an alternative use for ultrasound for us, but it certainly has been utilized in intracranial tumor surgery and as well as in the spine. So it's an important imaging modality, and it's been used for quite a while. As I mentioned, it's become more widespread in spinal cord surgery as well. The exact localization of tumors with intraspinal sort of intramedullary tumors can be detected as well, and that this is a large benefit to this technology. In intramedullary tumors, it's helpful for visualization of the transitional zone between tumor and normal neural tissue. Any syrinx cavities can also be localized, and planes between tumor and cord can be delineated readily. It was initially described in the early 80s. There's a bunch of different reports of its use. It seems to be right around the early 1980s where this technology sort of first became readily used. Toctus reported that the sensitivity of intraoperative ultrasound resection was up to 92%. And was effective in protecting spinal cord vasculature as well. This is a more recent overview of its use in this group out of Germany looked at 69 intradural spinal tumors, 42 of which were extramedullary, like ours was. This was between 2012 and 2016. Ultrasound was used before and after the durotomy, and really to delineate the exact location of the durotomy or the myelotomy, and after tumor resection to attempt to detect any residual tumor. The laminectomy levels, interestingly, were correlated with the preoperative MRIs, like you would expect, but then in about 7 out of the 69 patients, the laminectomy level needed to be extended. So you had about a 10% change in the planned bony resection in order to achieve adequate resection of the tumor, and that was based off the intraoperative ultrasound findings. So that was pretty interesting, and the results revealed the effectiveness of ultrasonography in terms of the amount of the laminectomy and durotomy location, like I mentioned. And this is another article, more recent as well, I believe in the mid-2000s, and they looked at 30 patients with intradural spinal tumors and 18 males, 12 females, and basically most of these tumors were extramedullary meningiomas like ours, or neuronomas, or metastases. These were the main types of tumors that they had in their cohort. But also, they did note that the ultrasound altered their approach in about 16% of their patients, where they had to expand the laminectomy to reach the tip of the lesion. So they just sort of noting the helpfulness of this technology. And then just a couple cool photos from this review from Clinical Neurosurgery Journal, showing what some of these views actually look like. In our case, the tumor was dorsal to the spinal cord, so we were able to see a lot of hypoechoic region where the tumor. I wish I had the photos, but basically there was a hypoechoic region proximal and distal to the tumor, and that was because basically you can imagine if this ball was dorsal. These regions were hypoechoic dorsally, where there was excess CSF. So it was really obvious the extent of the, just reverse this in your mind with cord and the hypoechoic regions. But in any event, I thought it was pretty cool. And then this is using low ultrasonography to look at that medullary tumor in this article, but then you can correlate that to in the open situation here, showing how that correlates to that vasculature, and you can see the extent of where it goes, and it's certainly helpful in these more complicated excisions. So it was a really cool case. Thank you, Dr. Malone, for allowing me to have some fun in there, and that's all I got.
Rob, this is a
great job, man.
The great case. One of the other indications for ultrasound that we used a lot, a few years ago, was in the evaluation of the adequacy of decompression in burst fractures in trauma. And you do, fracture reduction or decompression from the back or so through the pedicles, and the ultrasound, helped to, see if the anterior compression is gone. So that's another use of ultrasound intraoperatively.
Oh, that's really great. Yeah, I didn't know that.
Yeah, that's actually an awesome use. Dr. Ray, I've done that as well. Like if you've got a burst fracture ventral fragment that you're not sure if you're able to tamp it down and reduce it if you're not doing a corp, or also for CSM. Marge, Daddy's on a conference call. Sorry. For cervical myelopathy, it's nice too sometimes. It's super, quick and fast.